Metabolic bone diseases. Our final stop on this deep dive is the direct impact of calcium imbalance on the bones themselves, leading to metabolic bone diseases like rickets, osteomalacia, and the big one, osteoporosis. Rickets and osteomalacia. Rickets and osteomalacia are essentially the same underlying problem, but occurring at different ages. Both are caused by defective mineralization of the bone matrix. The collagen framework gets laid down, but calcium and phosphate aren't incorporated properly to make it hard. So the bone stays soft. The primary cause, overwhelmingly, is severe vitamin D deficiency. Without enough active vitamin D, you don't absorb enough calcium and phosphate, and vitamin D itself plays a role in mineralization. So the bone matrix, the osteoid, doesn't calcify properly. What's the difference between rickets and osteomalacia? It's about timing. Rickets occurs in children whose bones are still growing and whose growth plates are open. The defective mineralization affects the growth plates, leading to characteristic skeletal deformities, bowed legs, thickened wrists and ankles, changes in the rib cage. These can be permanent if not treated. So rickets is soft bones plus growth plate problems in kids. Osteomalacia is the term used for the same mineralization defect occurring in adults after the growth plates have closed. So you get the poor bone structure, the unmineralized osteoid leading to bone pain, muscle weakness, and increased fracture risk, but typically without those gross skeletal deformities seen in rickets because the bones aren't actively growing in length anymore. Same cause, different presentation based on age. Thankfully, due to vitamin D fortification of foods like milk and increased public awareness, severe vitamin D deficiency causing overt rickets or osteomalacia is relatively uncommon in many parts of the world today. But it's still a risk for those with very limited sun exposure, poor dietary intake, certain malabsorption syndromes, or severe kidney or liver disease affecting vitamin D activation. It hasn't disappeared entirely. Then there's osteoporosis, a name probably everyone has heard, but maybe the true impact isn't fully appreciated. Osteoporosis is by far the most prevalent metabolic bone disease in adults. It affects millions and millions of people, particularly in the US and Europe, with a significant female predominance, especially after menopause. The consequence is fractures. The definition is based on low bone mass and deterioration of the bone microarchitecture, leading to increased bone fragility and susceptibility to fracture. It's responsible for something like 1.5 million fractures annually in the United States alone. Hip fractures, vertebral compression fractures, and wrist fractures are the most common, and hip fractures are particularly devastating. What's truly striking and often underappreciated is that hip fractures carry very significant morbidity, loss of independence, chronic pain, and also a substantially increased mortality, an increased death rate. About 20% mortality in the first year after a hip fracture. That's a figure that's actually on par with mortality rates from breast cancer. It really puts the severity into perspective. It's not just a broken bone, it's a major public health issue with serious life-altering and potentially life-threatening consequences. Risk factors. What are the main risk factors? Who's most at risk? Some are non-modifiable. Advancing age is a big one. Bone loss accelerates as we get older. Being female, particularly postmenopausal due to estrogen deficiency. A family history of osteoporosis or fragility fracture. Low body weight or small frame size. Certain ethnicities have higher risk. Then there are modifiable lifestyle factors. Smoking is detrimental to bone health, excessive alcohol consumption, low dietary calcium or vitamin D intake, a sedentary lifestyle, things people can potentially change. And then there are certain medical conditions and medications. We mentioned primary hyperparathyroidism can affect bone. But a huge one is long-term glucocorticoid therapy. Steroids like prednisone are very bad for bones, especially with long-term use at higher doses. Glucocorticoids are particularly harmful because they deliver a double whammy. They inhibit the bone-forming osteoblasts and they stimulate the bone-resorbing osteoclasts. Plus, they can reduce calcium absorption. They attack bone from multiple angles. It's a major cause of secondary osteoporosis. Anyone on long-term steroids needs careful bone health monitoring and preventive strategies. How is osteoporosis diagnosed? Is there a blood test? Interestingly, no. There are no specific lab tests for osteoporosis itself. Most people with primary osteoporosis, the age-related or postmenopausal type, have completely normal blood levels of calcium, phosphate, PTH, and vitamin D. Those tests are important to rule out secondary causes, but not to diagnose osteoporosis itself. Diagnosis relies on assessing clinical risk factors, sometimes using fracture risk assessment tools, and crucially, measuring bone mineral density, or BMD, the bone scan, usually with the DEXA scan, dual energy X-ray absorptiometry. It's a low-radiation X-ray that measures bone density, typically at the hip and spine. The results are reported as a T-score. The T-score compares your bone density to that of a healthy young adult of the same sex. A T-score between -1.0 and +1.0 is considered normal bone density. A T-score between -1.0 and -2.5 indicates low bone mass or osteopenia. It means your bone density is lower than normal, putting you at increased risk, but not yet osteoporosis. Kind of heading toward osteoporosis. A T-score of -2.5 or below defines osteoporosis based on BMD criteria. Or importantly, osteoporosis can also be diagnosed clinically if someone experiences a fragility fracture, that's a fracture from a fall from standing height or less, or with minimal trauma, regardless of their DEXA score. A fragility fracture implies the bone is already pathologically weak. So a low-impact fracture automatically means osteoporosis clinically. It's treated as such because the risk of future fractures is very high. Treatment. What's the treatment focus? Treatment for osteoporosis always focuses on one main goal: fracture prevention. Stop the brakes. This starts with lifestyle measures, ensuring adequate dietary calcium, usually aiming for 1200 to 1500 mg per day total intake, and vitamin D, typically 400 to 800 IU daily, although sometimes higher doses are needed if deficient. Weight-bearing exercise is also important, as are fall prevention strategies, the basics. What about medications? Medications are a key part for those at high risk. The most commonly used class are the anti-resorptive agents. They work primarily by slowing down the osteoclasts, the demolition crew, putting the brakes on bone breakdown. The most well-known are the bisphosphonates, drugs like alendronate, risedronate, zoledronic acid. They're very effective at reducing fracture risk, especially vertebral fractures. Are there side effects? Yes. With the oral pills, the main issue can be upper gastrointestinal irritation, like esophagitis or ulcers, especially if not taken correctly. You need to take them with plenty of water and remain upright. There are also rare but more serious potential side effects that get discussed, like osteonecrosis of the jaw, particularly in cancer patients on high 4 doses, and atypical. And maybe here's a final thought for you to mull over as we finish. If calcium, something we mostly think of in relation to just our skeleton, has such a profound and complex role in nerve function, muscle contraction, hormone regulation, and more, what other invisible balances may be involving other minerals, electrolytes, or hormones are happening inside your body right now, constantly working, supporting your very existence that you rarely, if ever, stop to think about? And that is all. See you next time. Don't forget to subscribe, like and share.